My name is Dr. David Maddy, and I teach at the University of Louisville School of Dentistry. And this is a mini series of lectures that I created designed for dental students that I title Functional Occlusion and Advanced Restorative Concepts. Most of the content of this mini series comes from a book written by Dr. Peter Dawson titled Functional Occlusion From TMJ to Smile Design. There will be some references from a book written by Dr. Occlusion titled Management of Temporal Mandibular Disorders and Occlusion, and there are several animations throughout this mini-series by ByteFX that help illustrate three-dimensionally the complexities that are involved. And there is an icon in each appropriate slide that has a reference from one of these sites. This is lecture number 8 in the series that I title Removing for Preserving, Equilibration. Before we can begin to have any kind of conversation of treatments with the occlusion, we must first start with a diagnosis. And to get the diagnosis, it begins at our first meeting when we do our TMJ occlusal examination. Now, when you're doing that examination, a simpler way to think conceptually about what you're trying to understand is that you would like to best compare your findings to a perfected occlusion. So when you're looking at the TMJs and the condyle, you want to see the position and the seating. When you go to the front and evaluate the teeth, you need to look for contact and guidance. And then you want to end by looking in the middle and seeing if the back teeth don't rub. But the idea is that you're comparing your findings to what we have defined as a perfected occlusion. And so now we have a patient, we have a diagnosis, and we've determined that there's occlusal disease. And we found that there was a CO-MIP discrepancy, meaning that the posterior teeth are keeping the condyle from being in the most superior position, such as this picture shows. We see that there's group function, there's bouncing contacts, there's minor occasional muscle symptoms, but the joints are stable, and we verified that by load testing. And in this case, all the posterior teeth are fine, and we do not need any restorations. And these clinical findings were verified by the examination in centric relation mounted study models. But we have something like this occurring. Edges are chipping, breaking down. And if you remember, we categorized our patients after this examination into green, yellow, and red. And the green people were go, which means you could just go directly into treatment, working in their MIP without consideration of condyle position. And the red people were having problems. Their joints were unstable. And we needed to stop and treat the joint first before we would treat the occlusion. But most of them, as we said before, are yellow. There's instability, there's wear, maybe mobility, migrations. But we have verified that that joint is stable. And on these people, we told you before, we want to treat the occlusion. And then we said that there were 4 good ways, or permanent ways, let's say, to treat the occlusion. And so today, we're going to talk about reshaping teeth. And we do that, we call that an equilibration, which is the correction of stressful occlusal contacts that interfere with the normal jaw function by selective reshaping of tooth surfaces. Now, we do this to protect. So you ask yourself, gosh, we're taking away tooth to protect tooth? Well, yeah, you are. Because by taking away tooth, you will then manage forces. And if you manage the forces, you'll have less destruction through time. And then on our last lecture, we talked about splints, and I said that sometimes a splint might be a longer term treatment than maybe it could or couldn't be. And a good example of that is, let's say that you're kind of new and you're getting out and you don't yet know how to do an equilibration or don't have the confidence to, but you have that scenario of that patient we just described. There's no posterior work to be done, but you really aren't comfortable yet doing an equilibration. Well, you can make them a splint, like we said, but in this case, it would be a pretty good holding pattern for them for a while until maybe you developed your skills. Dr. Dawson would say that if proper equilibration procedures are performed on properly selected patients, the level of predictability is near 100%. So why do we equilibrate? Well, we want to eliminate occlusal instability. We want to eliminate prematurities from CO to MI. We want to establish the forces down the long axis of the tooth. We want to protect teeth from fracturing. We want to minimize harmful effect of hypermobility. And we want to create less muscle activity when growing into excursive movements. A few Dawson truths. Proper equilibration procedures can never harm a patient. Proper equilibration never restricts. Proper equilibration is stable. Notice the key word is proper. Doing a poor job or being improper is far worse than leaving the malocclusion because you've actually created new interferences with which the patient must learn to cope. The procedures: first you eliminate the COMI slide, then you eliminate all incline contact, eliminate lateral excursion interferences, eliminate protrusive excursion interferences, and then harmonize the anterior guidance. This animation will give a visualization. So we have a closure so that when that patient goes into centric relation, there's an interference in the posterior. You mark it with your tape and you remove it. You remove it so it doesn't interfere and it allows closure of the teeth. This is conceptually the idea. Always wanting to leave cusp tips and fossas. When you're done, you should have something that looks like this. We say the lines are in the front and the dots are in the back. The lines are the excursive movements, and the dots are the cusp tips and flat spots. Flat spots can either be fossas or marginal ridges. Here's an example of models that we would have the students equilibrate in some years past. We didn't carry it to the anterior for sake of time, but you see the maxillary lingual cusp tips all have a contact, and they're opposing into the mandibular fossas or flat spots, and vice versa. But there's something I wanted to show you, and that's why I have these models, is there's one little area that could have been a little better. See if you can identify it. Remember we said don't leave any incline contact, only cusp tips and fossas. Well, if you look right here, that's on an incline. You got a visual three-dimensionally from the tip of the cusp to the marginal ridge. That would be an incline area. We don't want that. Sometimes, though, we don't necessarily reduce or remove teeth structure, but we can add tooth structure. We would call that an additive equilibration using our composites. And so here's an example. As they close, this is the finished goal, cusp tips and fossas and incisal edges against cingulums and the maxillary anterior teeth. And this is a very nice completed idea right there. And so now we have someone that has a interference and they're worn teeth and the cusp tips are flattening. And it's been some time that this destruction has been occurring. And so we sometimes need a splint in order to manage the excessive muscle activity. But if we do or don't, we reach this point, we close, and we find that there's contact first in the back. But in this case, we decided not to reduce, but to only add. So we use some composite. We add it onto the surfaces so that when we're done, we end up with these cusp tips and fossas and incisal edges. Probably more commonly, though, you use a combination. You do some reduction in some areas and you do some additive in others. You might find in your practice equilibration on your study models that you have to be too aggressive in the posterior area before you finally get good anterior contact. And so you mark it with your tape, and you see that there's some adjustment that you could do. You have some room. You practiced on your study models. And so there might be in the very far back areas you can reduce. But then you might determine that you can't go all the way to the front. Maybe you can only make it to the premolar without being too destructive in the back. Or maybe you'll find that you can do all the back, but you can't get the anterior contact. And so you have to think in terms of combining. And so in this case, there wasn't any good guidance. There wasn't good anterior contact or guidance. And so there was some composite added to the front so that when the patient would close and slide forward, you would end up having immediate posterior separation. Or you might find you're in group function when you go to the right or left. So you might want to add to the canines. See, this is a good way to do a test run before maybe you might be restoring someone. Because sometimes when you steepen or lengthen these areas of the teeth, you might cause breakage. But if you do a test run in composite, you'll find out if it'll hold up through time. Some guidelines from Dr. Dawson. If you need to diagnose carefully before the equilibration. You to verify the centric relation before adjusting each and every time. You evaluate on mounted steady casts. You inform the patient. And you don't start unless you and the patient are prepared to complete the equilibration. And so for a novice, this is one of the most difficult parts. You'll get involved into it. You'll go so far. You'll think you're reducing too much. You're not sure of when to stop. And so it's always best to have good training or someone to really hold your hand or to show you. And remember, don't start unless you're prepared to complete. You got to be very, very precise. And also prepare the patient for subsequent further adjustments until the occlusion becomes stabilized. It's common that you might see them 3 times, 4 times. The first time you do the bulk of it, but then teeth tend to move and shift a little bit. Or you might find that they're feeling something heavy. And so it does take subsequent adjustments, but you need to prepare them so that they understand. Here's an example of an equilibration in the mouth. You see there is a small COMI discrepancy with a little opening in the anterior as the models show to the right. And this is Dr. Cranham. And you notice he's using what's called bimanual manipulation in order to allow that condyle to go into its most seated position. Then he's using his hands to hold it and load test it. He just had the patient tell him where the first contact was. So now he can put some tape in and see if that first contact on the tape is the same as the patient perceives. So he has him chomp into him while he's holding him, while that condyle is in the most seated position. And you'll see there's a inclined contact, exactly where the patient perceived it to be. So he takes out his dental drill. In this case, he's starting out with a kind of an aggressive diamond initially because he needs to do a little bit more reduction in the back. So he uses the tape, he marks it, and now he's going to take away that inclined contact, which was the first contact. Put the tape back in again. Again, he's still guiding or holding that condyle while it's seated. Now he's shifted to a carbide football, which is a smoother, less aggressive cut. It minimizes how much post-polishing that you need to have. If you finish with a diamond, you'll have scratches and it'll be rough. And you notice that same contact is still there on that incline of that second molar. It's not gone yet. Moisture is always a problem. You notice he has dry foils on the side and he's using cotton rolls. The more dry you can keep it, the more accurate your markings will be and the better they are to see. Again, there's an incline. He's leaving the marginal ridge. That'll be the flat spot. And he's taking away the incline that rides up towards that lingual cusp tip. Notice he shifted the tape this time. Now we're into a more accurate tape. It's called AccuFilm, and it will not give false marks. It's a wonderful product made by Parkel. So that's an incline contact he's reducing. That's an incline contact. Now, often you leave remnants. You see he left a little bit because he's going to wait for it to come a little bit bigger next time. Here is a big cusp tip. Now that's little tiny incline towards the center of the tooth he's doing. Being very, very precise. That's a big incline there. Again, we're looking at inclines. He's leaving the tips. That's the lingual cusp tip, and make that one a little smaller. When you're done, you want to have them all about the same size and equal intensity, and that's a teeny little incline going up. We're starting to look better, though. You see we're getting our cusp tips and some fossas, or flat spots. That's on an incline, and he'll leave a little remnant as it runs up. Now he's going to go into some excursions. You see he changed the tape to a red. He had black before. Now he's using red. He's having the patient go right and left. And what he'll do is he'll be able to compare what's centric versus what's eccentric, or movement. And as he looks, you'll see that there are some group function on the buccal cusp tips of that premolar. We're going to take that away. We want to end up with canine guidance, nothing in the posterior. Remember, immediate posterior separation. Okay. Looking at the other side, it's going to clean it up a little more, make them a little smaller, a little more precise, get rid of a little bit of the incline that's occurring. Again, this is a precision procedure. Doesn't take a long time. You can get pretty efficient at it, 30, 40 minutes maybe on the first appointment. He's going back and forth, working more on excursions. Fine tuning, a couple points in that fossa. We really only want one. Little incline contact there you got rid of. You might find also as you proceed, you might have had a little mobility on the tooth because of an incline, and as it kind of settles into its new place, you might pick up a mark you didn't have before. Now he's going into protrusion. He's going to finish up by harmonizing the anterior guidance. See, he doesn't have it on as much on one side as the other. And so, again, back to the right and left lateral. And we're just about finished for the moment. Of course, he'll bring this patient back in a couple days to a week and continue and do it 2 to 3 to 4 times. Now, sometimes you're seeing someone and you're in the middle of something and you are not ready, or it's not time yet for a full calibration, and you might need to do a little bit of localized selective grinding. And if you remember that if you always leave the cusp tip and fossa, and not you won't shorten, you won't take the tooth out of occlusion, and you won't create instability. So the key is to don't touch the tip or the fossa, but you can touch the inclines in between. And you can eliminate these incline contacts. And sometimes you're working in an area, you're putting the filling in, and you see it, and it's good right then to get rid of some of those inclines as you see them. Now this is something that is really fun to experience your first couple times. You'll have a patient come in and they'll feel like something's tall or high. Maybe you did a filling, maybe it's a crown, or maybe it's just connected to nothing, and they feel that their tooth feels tall, feels high to them. Well, if you put the tape in and mark it and have them grind around, and if you just adjust the inclines first and don't touch the tips or the fossa, and then of course they're not numb, and then you ask them to close and see how it feels, you'll be surprised how often they'll say, gosh, it's better. But if you think about it, you didn't take it out of occlusion. You know, what they were sensing was the incline contact. And the incline contact is often uncomfortable. So try that the first time somebody comes back that way. You'll be surprised. Here's a patient with a lot of wear that has occurred through the years. You notice that the premolars have the red mark. They're in group function. And that many of the posterior contacts are wide and broad, and the cusp tips are worn. If we look right here in this second molar, we see that non-working and working contact are all built into the same tooth, and this back tooth is really, really rubbing. And so we look at the tooth in front of it, and we see that it had a broken cusp. And so one consideration would be to do localized selective grinding, get this tooth into a better position of contact down the long axis. And so we just lightly touched it and allowed the marginal ridge and the cusp tip to stay, but removed the rest of the area. We got rid of the working and the non-working contact on that tooth. Another example, that patient might have come in with a sore tooth, let's say, but you haven't done a workup, or maybe this is someone that isn't ready for that workup, and they're in kind of a holding pattern, but they've come in and maybe tenderness or soreness. And so you can take that and eliminate those incline contacts and just leave that cusp tip. See how it does, see if it gets better. Keep it so it can't rub. Another example is this big, wide, giant contact, and which is going to lead to a possible fracture like you see in the picture to the bottom right. Well, it's okay to take that and leave that center contact point and remove all those other areas to protect the tooth. An example of selective grinding for protection to get the distal buccal cusp so it can't be in contact and lateral excursions. You see this a lot in the big worn teeth in the back. We call them blunder cusps. And there's really hardly any cusp left, and you have working and non-working. And again, this patient might have come in pain. And so it's reasonable to start by just eliminating all that excessive contact, leave the cusp tip in the fossa and see how they do. Gives you an opportunity to talk to them about why they should come in for a full workup to understand the total complexities of what's going on in their occlusion. Sometimes you're working in the anterior and you might be ready to do some crowns or something in the front or some bonding, and that you have a lot of irregularities. Well, this is localized selective grinding too. You need to be able to level out sometimes so you can have a good anterior guidance. Here's an example of a peg lateral, we call it. And maybe you're planning on putting a crown or bonding on that peg lateral. Well, chances are the tooth underneath it is worn, but not worn in the area where the gap is between the teeth. And so you would need to do a little bit of a selective isolated grinding in order to restore that other tooth back to its appropriate size. Examples of some post-equilibration. Notice the bottom left, those nice cingulum contacts onto those crowns. You see they're almost little ledges that were created to create it as horizontal as possible. So the real question is, how do you learn and how do you get confidence to do an equilibration on a patient? Well, first I'm going to recommend you do a lot of night guards. It'll help you master finding centric relation. You'll also experience patients' reactions to a balanced occlusion. They'll come back and they'll say things like, wow, my muscles never felt so good. My headaches are gone. Then sometimes they have instant relief when you're delivering and adjusting a night guard. And that'll just help you understand and appreciate the value of a perfected occlusion in muscle management and force management, and how if you allow that, if you modify that occlusion so that you have that perfected occlusion, you'll see that the symptoms subside. It'll give you confidence. So I'd say do a lot of night guards. You'll learn a lot. And then do some localized selective grinding here and there. Always practice on mounted study models. And anytime you're about ready to do an equilibration, it's always so wise to do it on the models first. This gives you a heads up as to how much you need to take off. It'll also guide you as to whether or not maybe you want to do a combination, reductive, and additive at the same time. And then most importantly, take some continuing education classes. Have someone to help you. Have a mentor. Watch a few times. Have someone teach you. Just don't start grinding on teeth. Because as Dr. Dawson says, an improper equilibration is more harmful.